All right, back live with you tonight. You're in Focus. Minister of Health, Dr. Motsoaledi, is discussing national health insurance matters with stakeholders in KwaZulu-Natal. The discussion seeks to address concerns surrounding the new reform. The minister joins us now for some more insight. Minister, good to have you, and thank you very much for your time. So you've been up since 5 a.m., Minister, and you are still at it. Your meeting lasting all throughout the evening. What are the people of KwaZulu-Natal say to you around the question of NHI?
Well, they raised quite a number of issues they didn't understand, Thabo, and good evening to you. To the effect that they did not understand this whole concept, and they are happy that I was able to explain to them, and they appreciated the fact that as they said in their own words, that I'm just not talking political rhetoric, but I'm putting figures, you know, graphs and figures and numbers and tables, which is exactly the aim of these road shows. I want to show people information which I know they are not privy to about what's happening now in the present healthcare system.
Yeah. So what are the pressure points? I mean, one of them, of course, which is what you've been talking about, you've run a whole lot of media briefings on this, medical legal claims. Now, in that particular province, 1,678 cases with summons with a contingent liability of 20 billion and with best value of 5.932 billion, which was recorded at the 31st December 2023 report. I mean, that is huge amounts that you're spending on there. How are you settling those cases?
Well, even though the issue of medical legal cases is not directly related to NHI, even though it affects financing, obviously, you are aware, Thabo, that we called a press conference on the 24th of August, jointly with the SIU, because of the investigation they've done. We are still busy with that. The SIU is still investigating. Some lawyers who did wrong things have been referred to the Legal Professions Council. Others have been referred to NPA, some to the Hawks. You know, we are very busy. Others who have cancelled their claims altogether with instructions from SIU. You'll remember that of the few cases they've investigated, they've already cancelled cases worth 3 billion rand as being invalid or being fraudulent. So we are heading somewhere, but it's still at the beginning of the investigation.
Yeah. One of the other issues in this particular province, others are boasting to say they managed to do it in their province, however, be it using external funding, is the whole issue of ensuring that there is a single electronic record-keeping system. That this seemingly is going really slow as far as KZN facilities are concerned.
Thabo, the issue of health information system is a worldwide problem. That's why the World Organization named 6 building blocks of a healthcare system. One of them is a health registration system, which has been evading us since 1994, but also evades many other countries around the world because IT companies are varied. Each one can offer you solutions that do not work. So we eventually dropped everything. We went to the CSIR, the Center for Scientific and Industrial Research, and asked them to use their IT expert. They've got many PhDs there in IT, and I used to meet them when I was in Home Affairs for them to improve our system. So we thought about them and asked them to design a system which will be interoperable between many systems in both public and private healthcare. And they have done that. We are busy piloting it, as I'm talking now. We are piloting it in the area called Ditlhabeng, the district called Ditlhabeng in the Free State. And once we've finished the piloting, we roll it all over the country. It will be a system that is used whether you are in public health or private health, because it will be an interoperable system. And we think that is a breakthrough once we start having that type of a system. We are not going to allow each and every province to use their own system alone, which cannot interact with the other system. There must be interaction. That's why we said one of the conditions we gave to CSIR is interoperability, meaning any type of system that you connect to that national system, they must be able to work together.
So you're saying this system that is run now, it seems far and wide in the Western Cape Department of Health, might not speak to the new system that you're talking about. So it would mean they might need to redo that whole system across all their facilities as well.
No, Thabo, many provinces have got their own systems. And many hospitals in the private sector also have got their own systems. For us to say, drop your systems and come to ours, it was going to cause problems, lots of problems, logistically, even sometimes legally. What we asked CSIR to do was to invent for us or design a system that will be interoperable so that no matter which system you use in your facility, it can be able to be integrated into ours so that they talk to each other, so that whatever information we have can be shared with the rest of the other hospitals. Remember, the aim of this whole hospital information system is that whichever doctor or whichever health facility you go to, when you go to visit a different one, they must be able to access the information which you left in the previous one, or access the information of what was done to you in the previous healthcare facility that we visited. And that system is the one that CSIR has designed for us, and that's the one we are piloting. So whichever province, whether Western Cape or whichever, had their own system, will make sure that it can be integrated into this national system. Because the one CSIR has done is owned by the state and is going to be a national system. It's not a tender, Thabo. We did not go to any company and tender for a system. It's a homemade for our own, and we own it, and we own the license, and we are not going to have problems about payment of license fees and all that.
Yeah. Now, I'm sure you've heard this debate. One of the debates, and I suppose it's even more relevant in KwaZulu-Natal just because of the legacy of special planning there, is that the NHI implementation, where one can be able to walk into any facility, be it public or private, is not going to benefit people in rural areas because they live in far-flung spaces where there aren't any private facilities anyway. So they're going to have to be forced to use the available public facilities that are there. And if those are not brought up to speed, then they're not really going to bear the benefit of NHI. Did that debate come up today?
Well, the debate about facilities, Thabo, is something that I bring without anybody asking. Because NHI does not mean private. It means all health facilities. We are arguing that South Africans must be able to use all health facilities that are available nearer to where they say. If it's a public health facility, they must use it. Because we can't say now that there is NHI, leave this public facility because it's of low quality, go to a private one. At any rate, there are not enough private hospitals in South Africa to cover all the people. The whole population is not possible. You are aware that at the moment they are saving only 14% of the population. What will happen to the other 86%? So for that reason, the Office of Health Standard Compliance will check all the facilities, public or private, and make sure that they comply with certain standards so that anybody can use those facilities. So the issue here is to build them. That's why I made an announcement last month that we are going to go to PIC, the Public Investment Corporation. And on Monday, we went to Treasury to make that proposal, that we need money from them to be able to build public facilities all over the country, in the same way as PIC is funding private hospitals. Even yesterday, the CEO, Mr. Stoll of the CEO of Public Investment Corporation, PIC, confirmed that they are funding a lot of private hospitals and they've got equity and share in those. We are the public, we can't have equity and share, but we'll be able to pay them over the next 20 or 30 years using the budget that we have got. In other words, we leverage the budget. Just like when you go to to a bank, they buy a house for you on a bond and you pay it over a period of 20 years. That is the plan, and we are discussing that plan, and we are saying, because that is already being done to the private hospital sector. And that's why they look so good. It must also be done to the public, especially that PIC is a public facility.
So let's stay in KwaZulu-Natal as well. I mean, the DA there, your partners in Government of National Unity, but also Provincial Unity for that matter, seem to believe that there is a challenge around response times to P1 emergencies. I'm sure you know what that means. I'm not really sure. But they're saying one of the issues is the fact that you are not meeting the ratio currently in KwaZulu-Natal of 1 ambulance to every 10,000 people in the province. What do you know about that, and how is that being resolved?
Ratios all over the world are ideal, Thabo. The ratios come from several structures. It might be World Health Organization or United Nations itself or OECD. They come with ratios. To meet them is ideal, but it's not always possible for countries. For instance, we have got ratios of how many doctors per population. There are not many countries that have arrived there, or how many nurses for population. In safety and security is how many police for population. We are building towards there. So what you are talking about is how many ambulances per population, and we are building towards those. Now in the private sector, because they are saving so few people, 14% of the population, and they've got 51% of the total health spend, health expenditure of the country, it will be very easy for them to reach those ideal formulas, but ideal ratios. But for the public sector, with 86% of the population with meager resources, it will be difficult. It's something that we want to build up to, but you must be aware that the reason you want universal health coverage, for everybody to be covered universally, is to deal exactly with those type of problems.
And were you able then to convince the people, you think, to come to that understanding, to say, just because we've got these challenges, which, as you put it, some of them are worldwide challenges of integrating systems, one system that speaks to one another, of the ratios that need to be met as far as vehicles are concerned. These are not reasons enough to say, let us not go ahead with NHI.
Actually, Thabo, the problem is NHI is clearly misunderstood. There's a belief here that is a vintage system which you put up when you have got everything, whereas actually it is a solution for you to start having facilities. That's exactly the reason that NHI exists. This story in South Africa that you must have this first, that first, that first, I don't know where it came from. Let's give you an example of UK. The system that we want to put, we are trying to copy what is in the UK, NHS, which was established in 1948. When the UK established that system, Thabo, they were in a worse state than we are at the present moment. It was 3 years after the Second World War. If you know your history, you'll know that the UK was battered by Hitler during the Second World War. And 3 years after the war has ended, they were very poor, unemployed. The economy was battered. That's what scared the British, that we've got so many poor people who are sick. Some of them won't be able to afford health care. And let's start a system that will cover everybody. They started the NHS precisely because they knew when you have got so many sick people who cannot afford, you can't build the economy, because sick people cannot build economies. So when you treat everybody equally whenever they are sick, you are actually building the economy. The example I can give you is HIV/AIDS, Thabo. Let's remember back around 2009, the year in which we started changing towards a new direction in the fight against HIV/AIDS. During that time, life expectancy was very low. There was a lot of absenteeism at schools. In places of work, there was absenteeism, but we put people on treatment. And now life expectancy has gone high. Things have improved around things have improved around the country. If we left it, then I was still telling the business people from Busa when we met with the president that if the state did not act to make sure that everybody get ARVs, many businesses will have collapsed. The economy won't be what it is. You saw during COVID, Thabo,
yes,
how the economy tangled. Yes. And you can imagine if you leave your people to get sick and not treat them because they don't have money, your economy is going to collapse.
Minister, let me appreciate you. Let me give you time to go rest. Now, it's been a long day for you. Much appreciated. And thank you for staying up and coming through to join us tonight.
Thank you very much, Tabo. Thank you.
That's the Minister of Health there, Dr. Motsoaledi. Right, let's take a break. When we continue next, what's making news here on In Focus? Stay with us.